Medurstand. Understanding medicine.
I'm Professor Aziz-ur-Rehman, and today we're going to talk about this fixed ratio combination of basal insulin and GLP-1 receptor agonist. And we will be particularly comparing these two products which are available: insulin Degludec Liraglutide combination and insulin Glargine with Lixisenatide combination. Both are injectable therapies. Now, the little background: in diabetes, we always, I'm talking about type 2 diabetes, we always start with lifestyle changes and metformin, and then we move on to adding one more oral agent and then another one. After two oral agents, it is recommended that we should consider injectables. And after three orals, the maximum tolerated or the maximum recommended dose of three orals, of course, we do not have any other option other than adding an injectable. Now, traditionally, in the traditional recommendation, the first injectable used to be basal insulin. That is true even today for many patients, but for some, especially those who have this increased atherosclerotic aortic cardiovascular risk, or those who have existing atherosclerotic aortic cardiovascular disease, there is very strong evidence that the first injectable should be GLP-1 receptor agonist based on data. Now I'm going to examine the combination, because in many situations you might have started with basal insulin and then you would need to add GLP-1 receptor agonist, or sometimes you start with GLP-1 receptor agonist and still A1C is not at goal, you might have to add basal insulin. So I'm going to examine this combination. Basal insulin, any insulin, and GLP-1 receptor agonist, they are both very potent glucose lowering therapies, and combining them will provide a very good solution. And let's examine if that is true. Learning objectives are: number one, evolution of guidelines, particularly combination of GLP-1 receptor agonist with basal insulin. And the second objective is a quick comparison of mono components of two available such combination and the practical aspects. Optimizing injectable therapy, and you're all familiar with this algorithm. If somebody is on oral agents and we have increased it to 2 or 3, and if somebody is still not at goal, we could add GLP-1 receptor agonist, and we should start it and up titrate, particularly those patients who are 50 plus and those who have comorbidities or existing atherosclerotic aortic cardiovascular disease or risk factor for atherosclerotic aortic cardiovascular disease. So we start with a low dose, like in case of liraglutide, we start with 0.6 milligram, we move on to 1.2 milligram, and then 1.8 is considered to be the maximum dose of liraglutide. So if patient is not at goal, A1C less than 7, then we have to add another injectable, that is basal insulin. Again, basal insulin is started at a low dose. If you talk about Glargine, typically 10 milligram, 10 units or 15 units, and then we, based on fasting sugar, we increase the dosage and we monitor A1C, and we keep on increasing the dose of basal insulin till we get to the goal. Although there is no defined upper dose of basal insulin, but it is generally considered that we should avoid over basalization. Once somebody is on about 40 or 50 units of basal insulin and still not at goal, I think we need to move on to more complex combination insulin regimens. And on the other hand, if somebody was not controlled on oral and has already started basal insulin as per conventional approach, and he has reached the maximum 40 units, 50 units, and still A1C is not at goal, then you could go to more complex insulin regimens. But I think better would be to add a GLP receptor agonist and again start with a low dose and up titrate. So in both these situations, at a certain stage, you will be giving a combination of a basal insulin and GLP-1 receptor agonist combination. And since diabetes is a progressive disease, and if these patients live long enough, they would probably still need more complex insulin regimens, and that would mean with basal insulin 1 or 2 boluses or 3 boluses. So those regimens can be considered. So in my second presentation, uh, which is going to follow this one, and I'm going to examine if we have to give this combination of basal insulin and GLP-1 receptor agonist, why not to start with combination in some cases? Why not? I mean, we start with one and add another one. Why not then start with the combination and to have the maximum benefits? This will be covered in the next part of the video. Now, a rationale of combining these two blockbuster drugs. First, examine basal insulin analogs, and then we will take up these GLP-1 receptor agonists, and then we'll see how this combination is really very good. Now, basal insulin control nocturnal and fasting plasma glucose. Because it is basal insulin, it is not prandial, usually injected at night. Of course, it can be injected at any time, especially if it is long-acting basal insulin, but usually injected at night, and we usually monitor fasting sugar to adjust the dosage, because basal insulin primarily controls fasting sugar and uh, uh, at night also. So that is the strength. Another one, it is very simple to initiate. These modern pens are very convenient. Once demonstrated to the patient, patient's intimidation is immediately over and patient feels very comfortable. Just one injection a day, irrespective of meal time. So that's very convenient. And these long-acting basal insulin, they offer some flexibility also, 1 to 3 hours before or after the defined time can be given. And then it achieves A1C targets in about 50 to 60% of the cases. So that's a good response. Hypoglycemia remains a concern. Obviously, hypoglycemias are more common with prandial insulin and those insulin which are basal but have peak like NPH. But since this is also insulin, in some situation, if somebody has injected basal insulin and has not eaten and has done some exertion, there is a risk of hypoglycemia. So though the risk is relatively small, but there is a risk of hypoglycemia. Modest weight gain is also a problem. Any insulin, basal insulin, to my understanding, they cause less weight gain, but of course, there is possibility of weight gain, approximately 1 to 3 kg. So these are features of basal insulin. Let's examine GLP-1 receptor agonist. It has got pronounced effect on postprandial glucose. You all know, I'm sure by your previous knowledge, and if you have attended my earlier videos, you all know this GLP-1 receptor agonist, they enhance glucose stimulated insulin release from the beta cells. And it is like a prandial drug, so it would enhance glucose lowering effect of insulin. So mostly postprandial, and this is particularly important if you combine, this is fasting and nocturnal, this is postprandial. So if we are able to cover both fasting and postprandial, obviously there are very good chances that we will be able to bring A1C to a desirable level. It is also simple to titrate. These injections are also once a day, simple pen and irrespective of meal. So both they share this feature. They can be injected anytime. A patient can take it with meal also if that is a patient's preference, but that is not a binding. and it achieves A1C targets in 40 to 60% as a monotherapy, of course, over on the top of oral. So if this one achieves A1C in 50 to 60 and this one also in 40 to 60, so there is a very good chance that combining both, we will be able to achieve A1C in, I think, people close to 100%. Low risk of hypoglycemia. Theoretically, the effect of GLP-1 is glucose dependent. That means once glucose is normalized, there would be no further stimulation of beta cells by GLP-1 and there would be no further glucose lowering. So there should be no hypoglycemia. This is the theory, but of course, in extreme situations, there may be very low chance of hypoglycemia, but this hypoglycemia never becomes stage 2 or stage 3. Patient may have little symptoms and patient will eat something and then hypoglycemia will be over. But if used according to the instruction, this drug should not cause hypoglycemia at all. Weight lowering effect, or at least neutral effect. Now it has got effect on the satiety and on the gastric motility, and by these two mechanisms it is known to reduce weight. But if patient does not control his food intake, then of course there may not be any weight gain, but certainly it does not cause weight gain. Okay, so weight lowering effect, or especially if patient regulates his diet also and do some exercise. So I think if the patient does exercise and take this medicine, then I think there could be some weight loss. So combining these two drugs, the weight gain of insulin and weight loss of GLP-1 can balance each other's effect, and at the end of the day, you could get a very good glucose control without hypoglycemia and without weight gain because of the complementary and additive action. Both are very good drugs and both have complementary action, not just simply adding. Some features are added, but others are complementary actions. So that gives us a very good combination. So what should you expect from a combo? If you do use this combination, it should cover both fasting plasma glucose and postprandial glucose. So that would be great. And both are once a day, so should be convenient, and especially if you combine them in one injection. They should improve adherence because instead of getting two separate injections, patient will have to take just one injection. I believe if you combine these two, there will be some reduction in cost also, because if two drugs are dispensed in separate pens, the cost will be more. If two drugs are combined in the same pen, and the cost of pen will be shared, so there will be less price and lesser hypoglycemia. Now, one would wonder why adding GLP-1 receptor agonist would cause lesser hypoglycemia due to basal insulin. The reason is that when we add GLP-1 receptor agonist, then the total dose required will be reduced. So patient will be getting actually smaller amount of insulin. So that is why with the same glucose, with the same A1C, there will be fewer hypoglycemias. Now, this is the theory, and let's see if that is true. We have two commercially available such combination. One is insulin Deglira, IDegLira. I is for insulin, Deg is for Degludec, and Lira is for Liraglutide. So this combination, and the trade name is Zoltofy. And the other one, insulin GLarGLixi, IGlagrLixi. This is Glargine and Lixisenatide combination. I think the trade name is Soliqua. And these are the two combination. In both these, dose is titrated as per insulin component. In insulin, we usually call the units, so many units. And when it comes to this combination, we can call units. Some people still call it units. I think it's okay to call them units, but others say dose points. Certain dose point, 10 dose points, like this. So if you suppose use this combination, you would monitor the fasting glucose and you would titrate the doses upward as if you are giving insulin. and the maximum dose is defined by GLP-1 receptor agonist component in both. Because if for basal insulin there is no actually defined upper limit, you could go to any level, but in GLP-1 receptor agonist there is a defined upper limit. So in this case it is 1.8 milligram. In lixisenatide it is I think 3 microgram. So the maximum dose is defined about the GLP-1 receptor agonist. So if you're using this combination, you cannot give more than 50 unit of this and 60 unit of this, because the further dose would be limited by the GLP-1. So if you have achieved that dose and patient is still at that goal, then of course you would probably need to add a prandial insulin. What can we expect when combining a GLP-1 receptor agonist and with basal insulin in one pen? Now this is very interesting slide. This is basal insulin monotherapy. Okay, basal insulin monotherapy, you can see there would be reduction in HbA1c, there would be reduction in fasting plasma glucose, and there would be some reduction in prandial glucose also if we use basal insulin alone. Now, if we use GLP-1 receptor agonist as monotherapy, then you would expect again almost similar HbA1c reduction and similar fasting plasma glucose reduction, but more postprandial glucose reduction. This is GLP-1 receptor agonist as a monotherapy. And when we combine these two, then you can expect much better response in all three parameters. More A1C, more fasting sugar, more postprandial. So combining them makes very good sense when it comes to the efficacy, because both drugs, they have different mechanism of action and the ultimate action is the glucose lowering, so they are very good in combining them. Now, side effects, when we use basal insulin as a monotherapy, there would be some weight gain and there may be some hypoglycemia and there is no nausea, because insulin does not cause nausea. But when we use GLP-1 receptor agonist as monotherapy, there is some weight loss, especially if patient is counseled and patient controls his food intake. There is very little chance of hypoglycemia, and of course, because it reduces your appetite, initially some patients, they may complain of some nausea, but that is usually temporary, and especially if you start with a low dose and titrate the dose upward, then there should be very little chance of this nausea. But people do get nausea, so I think patients should be counseled. And third, if we use combination, this is very good effect on the side effects. Many of the side effects are neutralized. So the weight gain of basal insulin is neutralized and there would be still some weight loss if we use combination. Hypoglycemia would be fewer attacks because patient would be needing smaller amount of basal insulin, and nausea of course will be minimized again because patient would be needing lesser dose of GLP-1 receptor agonist also. So these are actually very good. I think there is a disclaimer that these arrow sizes, this just to explain the concept, they are not proportionate to the actual effects. Now let's examine these two available products component wise. First, let's examine the GLP-1 receptor agonist component, liraglutide versus lixisenatide. These two components, and first examine molecular structure and pharmacokinetic profiles of GLP-1 receptor agonist liraglutide and lixisenatide and compare it with native human GLP-1. This is native human GLP-1. I of course cannot go into the detail because of the time constraint, and this is liraglutide, which has got 97% homology to human GLP-1. That means it is only 3% different than human GLP-1. But this lixisenatide, which does not come from, it is not an GLP-1 derived, it is actually derived from exendin, and it has got only 50% homology to human GLP. So the color code shows us this is 50% dissimilar than native GLP. Half-life of native GLP is 1.5 minutes, so that cannot be used for therapeutic purposes, because for that you would need an infusion. Of course, infusion is not possible for long-term use. Of course, one day somebody might develop a pump, like we have insulin pump. Somebody might develop GLP-1 pump also. But currently, this is not used for therapeutic purposes. Whereas liraglutide has got half-life of 13 hours. So that makes an excellent option as once a day usage. And then this lixisenatide is relatively short acting. It has got a half-life only 3 hours. So it would cover one meal effectively, but not the whole day. This would cover the whole day. So this is the difference. So administration is limited clinical value because of ultra short half-life, and this is once daily, any time of the day, independent of meal. Not only any time of the day, in fact it offers the flexibility 2 hours before or after the fixed time can be given, because once you are on this drug for several days, it achieves a steady state level, and then injecting little early, little late does not disturb the steady state level. This one, lixisenatide, because of its short life, it has to be given with the meal, usually with the main meal, and within 1 hour before. Because otherwise because it's fast action, there is a possibility, if you do not combine it with meal, there is possibility of hypoglycemia. Okay, so these features, I hope that I have clarified the differences. Now, based on that, which one do you think is technically better of these two? To me, liraglutide looks technically better because it is one injection which covers all 3 meals. Convenient. Whereas lixisenatide it will cover only one meal, and the meal with which you combine it. Now let's see if the trials actually confirm that liraglutide is better. Now, comparison of liraglutide versus lixisenatide head-to-head trial, change in A1C over time and proportion of patient achieving targets. This is A1C. You can see that this one is liraglutide, this blue, and the light blue is lixisenatide. You can see that liraglutide gives you better A1C. Now here, the proportion of people who achieve their target A1C, if you make the target of 7%, then you can see more patients, 74% patient on liraglutide can achieve their A1C as compared to 46% on lixisenatide. Now, if you consider A1C of less than 7% with no hypoglycemia and no weight gain, again, liraglutide is a winner. You can achieve these goals with 60% in 60% people with liraglutide, but only in 40% of the lixisenatide. So the trials, I think, also seem to show that liraglutide is better. And further on, CV safety. You know, these days cardiovascular safety is always a concern. And let's examine liraglutide versus lixisenatide. I'm sure you already know this data, but I'm going to repeat it here. And the MACE trial and cardiovascular mortality in this trial, and this is lixisenatide versus placebo. In this study, it was shown that lixisenatide is not any worse than placebo. It has got no adverse atherosclerotic or cardiovascular risk effect. It has got no effect on cardiovascular disease. So it was safe. It is safe, but no additional benefit. But if you see the effect of the liraglutide, and this is the data from a very famous leader trial, and they studied MACE-3, and this also they studied MACE. There was 13% reduction, and if you use liraglutide against placebo on the top of all standard of care, it was seen that liraglutide people, they had 30% lesser chances of having composite MACE, non-fatal MI, non-fatal stroke, or cardiovascular death. So liraglutide is not only safe from cardiovascular point of view, it is actually, it extends additional benefits. So after seeing this data, I think summary of this part, liraglutide, lixisenatide, 26-week head-to-head trial, HbA1c reduction was significantly greater with the liraglutide versus lixisenatide as an add-on to metformin. More patients reached HbA1c target of 7% or less with liraglutide versus lixisenatide. Significantly greater reduction in fasting plasma glucose with liraglutide versus lixisenatide, and numerically greater weight loss with liraglutide. However, statistically significant significance was not achieved. So all parameters of diabetes were better with liraglutide as compared to lixisenatide. And in CVO trial, liraglutide was significantly better in CVD risk reduction, whereas lixisenatide was neutral. So after seeing this data, which one do you think is actually better? Comparing liraglutide and lixisenatide, I think, to me, if you believe in this data, which is true, so liraglutide is not only technically better, but actually the trials have shown that it gives you better glycemic control and it has got cardiovascular benefit also. Now let's now examine the other component, Degludec versus Glargine. The other component is insulin. These are both basal insulin, and let's examine them. This is Degludec. All basal insulins are actually modifications of human insulin, and this is the structure of human insulin. They made some changes and they made the Degludec. Degludec is the insulin. Once injected into the subcutaneous tissue, it makes actually polyhexamers, which slowly dissociate and then release and absorbed, and that has got very, very long action. They removed an amino acid and then attached with this fatty acids. Of course, this is very technical, but what we need to know and you need to know that this is a very, very long acting basal insulin. So similarly with Glargine, they have made 1 or 2 amino acid changes, and that also becomes, once injected, it does not make hexamers, it remains, so it actually makes polymers and it becomes very, very slow in action. Now comparing to twice as long half-life of Degludec versus Glargine. This is Degludec 25 hours half-life and Glargine 12 hours half-life. Now, if some injection has got half-life of 12 hours, it would be okay for once a day injection. Do you think there would be any benefit of having such long half-life as long as it is once a day injection? This is once a day, this has got longer half-life, and this is also once a day. What benefit we can expect from the longer half-life? The benefit we can expect from longer half-life is even flatter curve. This is flat, but this would be even flatter, and you can expect lesser variability in glucose. And let's see if that is true. 4 times lower day-to-day variability in glucose lowering fat with Degludec versus Glargine U100. See, these gray columns are Glargine U100, so there is significant variability day to day, whereas this Degludec has got more or less same action, similar action, so lesser variability in effect with Degludec as compared to Glargine. So that means lesser chances of hypoglycemia. CV safety of Glargine versus Degludec, and you see in this trial, the origin trial, where Glargine was compared with placebo, and Glargine was seen to be as safe as placebo, so no adverse effect of Glargine on cardiovascular. Whereas in DEVOTE trial, where they compared Degludec with Glargine, there was some benefit of Degludec. At least Degludec was also safe, but I think this graph shows you that there was some superiority with lesser chances of hypoglycemia and lesser chances of other issues, nocturnal hypoglycemia. Severe hypoglycemia and nocturnal hypoglycemia was less with Degludec. It has got better cardiovascular effect, but more important than that is lesser hypoglycemia and severe hypoglycemia. This is because of ultra long half-life and very flat curve. This is cardiovascular safety. In LEADER trial, they compared this liraglutide, and you have already seen it extended 13% benefit. And in DEVOTE trial, they compared these two things. I think cardiovascular point of view also favors Degludec as compared to Glargine. So summary of Degludec versus Glargine U100, and I'm comparing Glargine U100. There's a Glargine U300 that is perhaps has got better profile, so that may be more comparable with Degludec, but in this data I'm comparing Degludec versus Glargine U100. So combination, as far as variability is concerned, longer acting with lesser day-to-day variability with the Degludec as compared to Glargine, and lesser nocturnal and severe hypoglycemia with the Degludec, and better CV benefits. So after seeing this, what do you think, which insulin looks better? Glargine has got great data behind it and great experience. We have been using Glargine for more than, I think, 1.5 decades, maybe 2 decades. And Degludec is relatively newer, especially for our market. But I think as far as the profile is concerned, it looks that Degludec is better. So now let's examine the practicalities of these two combinations. So I hope I was able to make this point that combination of basal insulin and GLP-1 receptor agonist makes a great sense, and we have two available combination in one pen, and let's examine the practicalities, how we use them. This is insulin Glargine Lixisenatide, Soliqua, and it has got two pens. One is 2:1 ratio, the other one is 3:1 ratio. So we start with this one, and we titrate up to a certain point, up to 40 units. If A1C is not at goal, then we have to shift to another pen and then again titrate up to maximum 60 units. And if somebody is already taking a basal insulin and is more than 40, then we have to start with this. Okay. This is actually the detail which I just described. And if we use this, the other product, Zoltofy, which is a combination of insulin, Degludec, and Liraglutide, this has got only one strength, and it has started with the maximum dose is 50 units, and we usually start with the low dose, say 10 units, and then we gradually increase baseline, and it's very convenient. You start with pen and you stay on that pen till you achieve the maximum. So I guess this is more convenient. Of course, this has got one can learn how to use, but this looks more convenient. And once you explain a complex concept to a patient, then patient gets intimidated. I guess if you explain this how to use, patient will accept more readily. So out of the two combination, which one you think is better? I think to me it looks like this one is better. So I think some more details. Here we start with 10 units, titrate upward with pen A, and if patients needs more insulin, we move on to pen B. Here we start with the 10 dose steps, and if we are adding this to oral anti-diabetic agents, For example, somebody is on oral anti-diabetic agent and you want to use this combo as a first line injectable, you may start with 10 units. But if somebody was already on GLP-1 receptor agonist, you will stop their GLP-1 receptor agonist and start with 16 dose steps. And if your patient was already on basal insulin and you want to shift to combo, then again you will start with 16 and then you gradually increase the dosage. So the summary of this presentation: insulin, Degludec and Liraglutide combination, which is Zoltofy, offers a convenient and robust solution for people with diabetes not controlled with oral anti-diabetic agents and require injectable therapy, and it offers better A1C and blood glucose, weight neutral, fewer hypoglycemia compared with Glargine U100. And it is convenient titration and CV benefits compared with insulin Glargine with Lixisenatide. So this is actually a great combination and can be considered for those who are not responding to 2 or 3 oral agents and they require an insulin. In the next video, I would particularly focus on starting with this combination. In this, I examined all the possibilities starting with combination and moving from basal insulin to combo, or moving from GLP-1 receptor onto combo. Thank you very much. It was great experience talking to you. It is Professor Aziz-ur-Rehman from Medurstand. I hope you like my channel. Please subscribe, please watch other videos, and particularly watch the next video, which is actually second part of the same component. I really look forward to see you in my next video. Professor Aziz-ur-Rehman.